First of all, thank you everybody and welcome to the December meeting of the Appalachia Partnership Consortia meeting. There's a whole bunch of people in here, different people from different places, some from CEG, some from other places. And we've got a very special guest and a very special friend of mine. I'm gonna call him a friend, even though if he doesn't claim the title, I'm gonna say it is so. And Robin Jennings, I know you're on this call. You missed a staff meeting this morning, but I want to say congratulations on your scholarship that you won. I knew somebody won a scholarship. They didn't give me all the information, and I congratulated somebody else for your scholarship. But congratulations to you for your scholarship. So that's number one. I want to get that off the plate and out the gate, as they say. So Michael Kharfen, I'm gonna first of all let you introduce yourself. You're at HRSA, the Health Resources Services Administration, and you're the director at HAB, the HIV/AIDS Bureau, I believe. I think that's your official title. Well, maybe, yeah, it was a little bit. All right. And I ran into Laura Achiever the other day at the White House. That's right. I'm name dropping that I was at the White House and that Laura Achiever was there. I'm gonna name drop that. But what was even crazier is that the President of the United States congratulated Laura Cheever on her years of service. She got into a speech. Lee, that's a note for you. When I'm on my way out, you better make sure whoever the president is mentions me in the speech. So, Michael, the way this works is no slides, number one. Number two, a conversation really about the work of HRSA, a work about the HAB Bureau, what you do, what you're doing. So first thing is, why don't you introduce yourself to the people, and we will begin this conversation.
Great. Well, thank you, Tony. Thank you, Lee, and others from CEG to invite me to today's call. I've been looking forward to this opportunity.
Dodged it like a bullet, he did, people. Dodged it like a bullet.
No, I'm not that swift anymore. The years have settled in. So my title is I'm the director of the Division of Policy and Data in HRSA's HIV/AIDS Bureau. But Tony and I go back, more than 15 years. Previously, I've held positions in the federal government before in HHS, in the Children and Families Program. Most of my career has been spent in public health and in HIV, and that has been for 15 years, I was with the DC Department of Health, and half of that as the director of the HIV, hepatitis, STD, and TB agency, which was
a mouthful.
A mouthful and a great privilege to have had that position, and in that role, having had the opportunity to work with Tony and CEG for many years over course of a lot of different program initiatives. But I got my start working in HIV in 1985 in New York City, when I started working for David Dinkins, who was the mayor of New York City for a period of time, first African-American mayor of New York City. And it was at the height of the epidemic, and we had few community strategies. We were hamstrung by not having a coordinated federal response to the epidemic, and it was community that stepped forward, and some of us in local government who also took up that challenge to serve people and to do that. And so to me, I've had a varied experience at all these different levels, and it is a great honor to be at HRSA HAB now, as sort of a capstone of my career, working on the national Ryan White HIV/AIDS program, which has been from the beginning a program centered in equity, in social justice, and in community empowerment. And so we carry that for those 30, now going on 35, 34, going on 35 years of the program. My specific responsibilities is I oversee our work in all of our data collection for the Ryan White program, uh, which many of you who may have work within Ryan White know is pretty extensive. And we publish that reports and disseminate it through reports, but then also through a dashboard that we have called the Compass Dashboard. I also oversee our clinical quality and improvement team. So as we work with Ryan White recipients, as an opportunity to be able to advance innovative program and continuous quality improvement and quality management.
All right, Michael, you new to this. You're not true to this. So Appalachia Partnership works different. So I'm going to cut you off. I'm going to
Okay.
cut you, and the reason I'm going to cut you off is because is because of this. Because a lot of the folks that are going to be on this call
Yeah.
don't even know what Ryan White is.
Then let me step back a second and
Right.
just give you a quick one, a description. So the Ryan White HIV/AIDS program, it was started in 1990. It consists of multiple sections of funding to communities, to cities and metropolitan areas that were originally sort of the epicenter of the epidemic, and states and territories. And it also funds directly community-based organizations. We're set up in parts. So part A is the cities and counties. Part B is the states and territories. Part C is the community-based programs that provide medical services and other support services. And then part D is for women, infants, for women, children, and families. And that also funds directly community-based programs.
Okay, hang on,
Part F. Yes, Joni. Yes, Joni.
Michael. Okay, that was a lot. I'm gonna slow
That
you
was a lot.
down. All right. So Ryan White is a federal program. That means that the Congress says to the federal government, here's a program that's a priority, and I want you to admit, I want you to do these programs, and I want you to fund it. How much money are we talking about for Ryan White?
About $2.5 billion.
Okay,
Uh,
so
it, it,
2.5 billion, and that's
it-
for HIV, but that's for treatment, not prevention, right? So that's not prevention dollars.
Correct. So the Ryan White program was established to serve people who have HIV or are directly affected by HIV. So that can be family members, partners, and so forth. It was set up in honor of the young teenage boy who was diagnosed with HIV, and he became a spokesperson and champion for people with HIV. Then everybody was called it.
You're getting a lot of compliments in the chat. They say the person from they're saying from West Virginia, whenever they've contacted the Part B person, that they've gotten back to them right away. It's always been very quick, very rapid response. So they're applauding Ryan White in West Virginia. So
Awesome.
so Ryan White was a kid. Ryan White actually became really good friends with Elton John also, and was his mother Jeannie White was actually just introduced the president also at the White House on World AIDS Day, this past World AIDS Day. Jeannie has been an advocate since Ryan's passing many years ago, but has remained a staunch advocate for people living with HIV, particularly those that lived in rural communities, because that was one of the big challenges, was that Ryan, who was a kid, and I believe it was a hemophiliac, who
Correct.
contracted HIV through a blood transfusion, was thrown out of school. And they were told, he was told, get out of here, kid. You can't come in here with that. And so she strongly advocated for his ability to go to school, at that point, saying, look, it's not that the other kids will be able to contract HIV, and through that, and so that's how it came up with its name. Now we got a 2.5, and I know Michael's like, Michael, this is, to think about this is like rapid fire news TV from olden times, olden days. This is what this is. So, all right, $2.5 billion, Ryan White program. Part A, you said, goes to the
Cities and counties.
cities and counties. So cities and counties apply for this money like everybody else has to apply for a federal grant. No? Yes?
Correct. Correct. They have to have a certain number of people with HIV to be eligible. So it is not just any city or county.
Ah.
They're actually designated in the statute. So the law that Congress passed wrote in the actual areas in the country that qualify.
So are those the eligible metropolitan areas? Is that what those are
Correct.
called? Okay.
That's what they're called.
Okay, so eligible metropolitan areas. Now, West Virginia, now people are on this call from West Virginia, Kentucky, and other places, but for the sake of this argument, we're going to talk about West Virginia. West Virginia is actually weird, and not weird. I mean, anybody that lives here knows it's a little strange, but weird in that it is got two Ryan White groups that it responds to. So Jefferson County, Morgan, I think it's Jefferson, Morgan, and Berkeley counties are all a part of the DC eligible metropolitan area. Then part B or something
Just
else.
Jefferson and Berkeley.
Just Jefferson and Berkeley, not
Yes.
Morgan.
No, just the two counties.
Okay, so Jefferson and Berkeley are a part of the DC EMA, and then I think Ohio has the other part of the state. Do I have that? Is another part of the state from the Ohio EMA or something else? Because I think that we get money from two different Ryan White groups, don't we?
So as Martha notes, Part B covers the entire state. So it
Okay.
can overlap with a Part A area. So those in the Panhandle up in Northern Virginia, as Martha noted, she may also be getting Part B money, or there can be Part B money in those counties. So it doesn't exclude other parts. Off the top of my head, I can't think that there's a eligible area. The nearest would likely be Cleveland, and I'm not sure that that includes West Virginia. Columbus, I think is so there's different levels based on the amount of population. So there's the EMA, which has somebody put in a link there.
Yeah.
The EMA, which is covers the eligible metropolitan area, an eligible metropolitan area.
Now, I just said that whole thing about Ohio, and as everybody knows on this call, I've been wrong before. It wouldn't be the first time, but usually they don't figure it out till they get in the car, until the call's over. They don't figure out in the middle of the call. But here's my thing. Okay, so that's part A, cities and counties. Part B, part B is
states and territories.
so the states, and so okay, so that's part B. So West Virginia gets something there. Part C is the organizations, right? So they can directly apply. And then part D is maternal and child health, correct? Do I have it right?
That is correct.
Okay. So
then there's one more part though. With funding. Yes. So part F, and that covers multiple programs. It covers what's known as the AIDS Education Training Centers, AETCs, and they are funded by region. So and those provide education to providers, training to organizations and providers And that they can be funded or not funded under Ryan White. So there
Mm.
can be anybody who is trying to provide some form of HIV care can get support, technical assistance from these training centers. The other program, there is something called the dental. We have some dental programs where we fund dental schools to be able to train dental providers to serve people with HIV. And then we also fund some dental programs to provide direct services. The last part of Part F is called the Special Projects of National
Man,
Significance.
I've been trying to get money out of that tree for 20 years, but go ahead.
I know you know that one well. And that also is competitively awarded through grants that go to, it can go to a variety of different entities that are doing demonstration programs on HIV program models. That are, most of those are evidence-based or evidence-informed, and then they're learning about how they can be implemented in real world settings for the Ryan White program.
So, Michael, what I liked, how I like, thank you for that. Thank you for that background. And I think it's really important that folks who, kind of do the work in this space, like I always say, many of the people that we work with in the Appalachia region are seeing, HIV and hepatitis C as secondary or tertiary issues behind substance use disorder. And so, I'm going to give the train analogy as I always give in every meeting. Like I say, that there's a train roaring through the Appalachia region. The engine of that train is the Oxycontin crisis that we know. Now to poly drug use crisis, hepatitis B, hepatitis C, Hep A, economic development, workforce development, educational attainment challenges, with the caboose of that being HIV, and now a sidecar of syphilis. And I say that we've got to think about the fact that then that's laden with coal, the environmental impact of coal, economic impact of coal, and the psychological impact of lost coal jobs. And that what we have to do is bring resources, opportunity, and attention to the Appalachia region in order to address this. I also believe that, for the past 30 years, many of us in the HIV space, or at 40 years now, have been dealing with HIV outcomes, HIV responses. But, many folks in this part of the country have been dealing with an opioid crisis or substance use disorder, behavioral and mental health. Can you talk to us a bit about how it is that HRSA is working to bring in behavioral health providers, buprenorphine providers, Suboxone, methadone, or others, to make sure that we close the gap in what we in public health call the syndemic of HIV, hepatitis, and substance use disorder?
So, so HRSA the bureau that I work in is one of multiple bureaus in HRSA. So HRSA as an administration has some programs that you may be familiar with, but not necessarily associating with HRSA. So the biggest program is the health center program. So all of those federally qualified health centers or those lookalike health centers are funded, they get base funding from HRSA and from the Bureau of Primary Health Care. They serve like 30 million people across the country in urban, suburban, and rural settings. And that system of care, which serves as a safety net, but also through insurance, is sort of a core community-based health delivery system. And that can be inclusive of behavioral health. As you know, there's been a major push in the country to integrate behavioral health into primary care, and HRSA has been one of the agencies in HHS, Health and Human Services, that has been leading that effort to provide an integrated system of care so that someone can go into primary care and receive opioid use treatment in a way that can be non-stigmatizing, can be part of a comprehensive service, healthcare. So that has been a focus of the administration in terms of advancing that. It's one working with our other HHS partners like CDC, which has had the opioid they've had the opioid project that they were funded under. When I was with DC, we got some of those dollars. Also, SAMHSA has been obviously, its core mission has been working on substance use, but they've also been advancing not just methadone treatment, but now has been also focusing on buprenorphine-based treatment as a priority. So I think those are all of those HHS agencies have been working collaboratively to be able to make those opportunities available. SAMHSA changing the requirements for to be able to prescribe buprenorphine has been very important.
Right.
When I was with DC, that was my number one ask. I said, I can't believe that we don't put restrictions on prescribers to be able to give out opioids, but we restrict them in being able to treat people with opioid use disorder. It just was a backward.
Yeah.
Um,
Yeah, it was bananas, but also one of the other things that the FDA's done is allowed for the mobility and portability of
yep.
methadone being able to be done on mobile units, which was not available before. And I think that many people, especially those in rural communities that are having to do mobile and portable responses. Back in the day, we used to talk about kind of how to establish a medical home, and we knew
Right.
that medical homes were mobile and portable. We don't really kind of talk about medical homes in the same kind of framework as we did before. What I want to ask you about is kind of this, is that the idea of rurality, right? And I know you guys have a fancier name for it, but I call it the rule calculator, where you
Right.
determine kind of who are organizations and institutions that could apply for resources. Typically, HRSA really uses this tool. Other organizations use a different tool. Can you talk about the rule calculator for a minute?
So I have some periphery knowledge of it. I say that just because in HAB, in the HIV, in the Ryan White program, we're not using that calculator, that formula,
Right.
because we have a statute that has lots of other requirements and definitions in it, and that's not included in it. Now, that's not to say that the Ryan White program doesn't consider rural programs. We do. We publish data about it. The one thing is, and this is the interesting aspect of the Ryan White program, is while we collect client level data, we don't, we don't collect by name, so it's completely anonymous to us in the federal program. But we also don't really collect it by residence of the person. So what we do is we collect it by the provider. So where those services are delivered. And that's how we kind of define rural which is not as precise,
Mhm.
say, but as if you had the address of the person receiving the services. But it does help us get some a way of looking at rural services by where the location of the provider is. And that helps us in the HIV, in the Ryan White program, to be able to understand some of the dynamics of care for people with HIV in rural America.
And so when we think about that, right, again, I want to kind of build on what you just said. Is that so if we look at rurality, we look at HIV cases, we look at where substance use disorder is, what are the priorities right now for HAB Bureau, the HIV Bureau? I understand the Ryan White program and what it, because it's got a legislative mandate that
Correct.
it can't go outside of, right? And that's people living with HIV,
Yes.
those that are in their family, those that may need respite care, that sort of kind of care and treatment modality. But when you think about where we are with a syndemic approach, and it's my understanding that all of the federal government, as of right now, is taking what they call, what you guys call, a whole of government approach.
Yep.
So can you tell me kind of how HRSA plays in that whole of government approach responding to HIV, substance use, and substance use disorder?
Well, one thing is, as taking up your approach, Tony, is, we often slip into public health speak, and we do that in the federal government all the time. We do that in government all the time, quite frankly. But um, and we've now been for the past 10 years been using this term syndemic as a way to sort of represent that one condition is not independent. It's all connected to other medical conditions and or connected to other social factors, such as many that you just described.
Mm.
Financial, economic status, housing, transportation, all geography, all of those are factors as to whether or not people have good health outcomes or not, based on those factors in their lives. And so the Ryan White program, you described some of those services, but it's very comprehensive. It's always been. I often describe it as the original syndemic program because it always had, for instance, not medical care for HIV. So that's paying for the doctors and the nurses, but then also the medication. But it also covered substance use services, mental health services. It covered care coordination. So the person who helped that person understand about about adherence and taking their medication. It looked at other non-medical services, such as how to find help with housing, how to be able to address other psychosocial needs that a
Wait, what's a
person might have.
psychosocial need?
Well, psychosocial needs could be not a full level sort of mental health like a psychiatrist, but it could be counseling and other means that address social environments. It could be trauma, it could be abuse, it could be those types of which we know all of these can be factors that either help somebody's health or actually presents barriers to someone's health. So we in the Ryan White program want to look at people holistically, the whole person. We are a person-centered care approach. And so you can't sort of compartmentalize people to say, okay, oh no, I can't talk about your substance use because I can only talk about your HIV. Or I can't talk about your hepatitis because I talk only about HIV. And so what we've done in the Ryan White program is say, the funds that we provide to providers, to recipient, we call them recipients, but to the states, the cities, the individual community-based organizations, you can use those monies to pay for substance use services, to
Mm.
do buprenorphine treatment, to pay for hepatitis treatment, to address syphilis and other STIs. The major uh, uh, requirements are: one, the person has HIV, as you just described, and also there is income eligibility to this program
Ah,
because it is for low income people, and it varies from place to place in terms of what that area, what that state or what that city um, sets as their eligibility level.
now,
Um,
let me ask you this, and I'm sorry, I
that's
told you
okay.
already. Get ready for it. I'm rude, and I just interrupt. But what I remember is that Ryan White used to be considered what we call the payer of last resort. Is that language still used? Because it was like if
Yes.
you had insurance, if the city had Medicaid or Medicare, or if the man from the moon was going to come down and loan you $20, you couldn't get Ryan White. You had to wait until you spent your $20. Help me understand, or help the people understand, payer of last resort. What does that mean?
So that actually applies to a whole bunch of federal programs. It's not just to the Ryan White program.
Ah, okay.
So say Medicaid is also a payer of last resort. So it applies to a lot of federal programs that basically says if there's another program out there, federal or state, that could provide that service, that comes first. And if that doesn't, if a person is not eligible for that, then the Ryan White program, in this case, in our conversation, can cover it. So you're right to the point that says, but it's not exclusive. And what
Uh-huh.
I mean by that is that, so say the person has Medicaid. In fact, a majority of the people in the Ryan White program have Medicaid. A growing portion of people also have Medicare. And that's growing also because more than 50% of the people with HIV in the Ryan White program are over 50, and 25% of them are over 60. So we're getting older, which is a great thing.
Right.
But it means now more people are going to have that coverage. But what it doesn't mean is that because you may be receiving Medicaid or Medicare for your health services, it doesn't exclude you from other of the Ryan White services, say medical case management or non-medical case management, or because that other program may not cover that service. You might not get some levels of substance use services, so Ryan White can do it. So the program just has to document that, in effect, there is no other care available or service available, and then Ryan White can cover it.
So if I'm a person living with HIV, how do I know how to access where all of these services are? How do I get to these benefits? How do I get to even know that you're there, or that, I mean, when you are there, or how I get there, or how I access? Because you point out something that I think is really, really important for people to understand, is with, since we have gotten into an era of what we used to call high, heart, and then we got to antiretrovirals, and now we're at, I think that we're basically at what I like. It used to be in the olden times a two-tap solution was a police response, but I think that we're now at a two-tap response, two-tap solution, and when it comes to HIV, because what you can basically take an injection for either, 4 times a year right now, but it's going to be 2, and you can treat HIV, and you're untransmittable and undetectable like 99.9 something percent. You can then, and where we're going to be is that you can also take basically 2 shots, and you can, if you're not living with HIV, you won't contract HIV if you engage or come in contact with a person living with HIV. So I think we're going to be at 2 or 4 doses on either side of the spectrum. But the reality is that, again, I believe that. So here's what I believe, and you could say you're nutty. You stop believing that. And it
I've
is
known
okay.
you too long for that,
No,
Tony.
no, 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 because there are people on this call that already believe it. So this is why I say this is a friendly call. You can go, you're nutty. That's you're wackadoo. Don't say that again. Is that here's what I believe. We keep saying that we can't find 20 to 24% of the HIV cases in the United States, or that we miss 2024 every year. And then with hepatitis, we put that around 40% or something like that, right? Now, again, we've got the two-tap solution, or we've got a biomedical response. Let me clean that up, because then somebody will report that I said we killing people or something. So we got that. But then with hepatitis, we've got a 12-week solution that we can do where we can cure, right? In about 12 weeks, it'll take me to get you to a cure, right? So here's the,
Eight weeks. Most of them work in 8 weeks, but
but they say, but the bottle says
12 weeks.
12.
The
Most of
indication
them,
says 12, but we know that they work so well in 8 weeks, you're cleared.
right. So right. So now listen. But the question that I have is this: how is it that we're going to get the rural communities, Billy Bob and them, Mary Joe and them, not to see themselves as a part of the solution? Because what I've got to do is that I've got to get the providers who are out in the middle of nowhere to be able to say, hey, you know what? I'm going to treat HIV. I'm going to screen for HIV. I'm going to screen for Hep C. And I'm almost at the point where I'm like, I used to be let everybody test who when they want to test, and don't test when they want. But I'm almost at a, you know what? No, we need MAP providers testing for HIV.
Yep.
We need, and because I believe that the 20% of people that we can't find, that we say we can't find, and the 40% of Hep C cases I say they're sitting in rural America. I say that they're sitting in MAC clinics, and I say that we've got to do more to get them as a part of this solution, is what I say. And I think that the way that we have to do it is also, we can't put people in a position where they honestly don't see themselves in the solution. And what do I mean by that? I can't send them to a website like, and I'm just going to call them out, like Mr., and they see somebody that is completely opposite to what they see, how they see themselves. How do we do this? How do we get these providers as a part of our solution, or like I like to say, I don't think that we've gotten them as a part of our continuum of care, treatment, cure, prevention, and PrEP uptake. Tell me how we're going to do it, Michael, because I got a big job ahead of me, and I need you to tell me how to do it, because you're one of the smartest people I know, and let's go.
So you asked me sort of what's our priority beyond what the program is defined, and our priority is about those people who are not connected to care, or not consistently connected to care, to get into care. Because if we can reach that 220,000 or so odd people that are estimated, and CDC is doing a new calculation on that, then we can end the epidemic as we know it, as somebody from rural America said about welfare at one time, that we could make new HIV very rare. But how we do it, I agree with you in that we have to get beyond our comfort zones in the way that we provide services. The Ryan White program has been a tremendous success for the 570,000 plus people who received those services. Our latest data shows that 90% of those people are virally suppressed. That's the highest
What does that
number.
mean? What does that mean when you say they're virally suppressed? What does that mean?
That means that, as you said, they can't transmit HIV to someone sexual to a sexual partner. But what it means is that there's less than 200 copies of the HIV virus in their blood, which means that effectively you can't count it. It's so little. Doesn't mean that somebody's cured, because HIV is still in the body, but it's not in the blood, and therefore a person's immune system is not as stressed as it was when there was a lot of HIV in there. And basically, a person can live practically a standard lifespan. Of course, as you know, that varies from where you live in this country, in terms of what a standard lifespan is. And rural America and Appalachia, I believe it is less than in other parts of the country.
Right.
But that said, that's how successful the program has been, and is at this point. But there's a lot of people who are not consistently in care. And when I say that, it's because there's a percentage of people who don't know they have HIV. It's a smaller percentage of that. It's a smaller number of those 200,000 plus people. The most of that number are people who do know their status, but have been I tend to think they've been in and out of care, often because that care wasn't supportive of who they were, of other factors in their life. We believe in a harm reduction approach, which means not setting some of those preconditions in order to get care, but we know that's not consistent. And for some, so our message is now, you got to rethink the way you provide care. It may means that you may have to stop doing some things that you do because people are doing well with it. And then you got to think about new things, get outside of your four walls, like you've been describing, of your clinic, and be able to provide a version of care that can be, that can meet people where they are at, and be affirming of who those people are.
Okay, Michael, but I know you must have gone to the same media training I went to. That he said, don't answer the question that they ask you. Answer the question you want to answer, because you did a good job of that. You didn't answer the question I asked you. You answered the question that you wanted to answer, and I appreciate that too. But here we go. I'm coming back to it.
Come back to the question then.
All right. So
I
here,
got to do my first answer first.
right. See,
Then
right.
I
See,
can get
and
to your
what
question.
Michael didn't tell y'all is that he used to be in charge of communications, and so he's an expert at this. And so, and I've always learned so much from him. He's really good at what he does. So here's the thing. Question for you. I'm gonna come back to it. How do we get people who are in these MAC clinics, who are in rural communities, to be seen as a part of this solution? Again, if I open up the ad, or if I open up or I send Billy Bob, I want to have a conversation about treatment, or if I send Mary Lou down the road to have a conversation about treatment access, or a new program, or this or that, what Mary Lou is gonna see is an other. They're gonna see a they. They're gonna see a them. They're not gonna see a them. They're not gonna see themselves. What do I mean by that? I mean that we have. I mean, I don't think it's as simple as just a reduction in stigma. I don't think it's just that, right? I think that because the reduction in stigma is saying I got to get Mary Lou and Jim Bob to accept everything that's in front of them, rather than I've got to be able to give Jim Bob and Mary Lou a program that looks like them. that we have to see Mary Lou, and maybe we can see some ads with tractors in them. Maybe we can see some ads with corn in them. Maybe we can see some ads that say, "Hey, this is an issue for you too." We've been looking at this idea of doing this major testing initiative during a large event, 20,000 people, rule America, large concert series over multiple days. But then when I go to try and get the partnerships with the particularly around prep and prep uptake, when I look at those prep ads, I need to be talking to these people about prep. I need to be engaging them about prep. The problem is that they don't see themselves as a part of a prep solution. Help me understand what we're going to do.
Well,
I know you're like, that ain't what I signed up for. That ain't what you told
no,
me.
no, 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 no. I signed up for the whole thing. So the Ryan White program, and having been responsible for that program in DC's area, that included those two counties in West Virginia, by the way, um, is a community-driven program. The planning, the decision-making about how those programs are allocated, who gets the money, who are the participants in the Ryan White program is all done at the state and local level. And what I said to Tony when she was in the DC area, and to the other Tonys um, is that you got to work with those local entities to say you need to include us in that decision making, um, and in how those funds get allocated, and who and how those programs are designed, and how they are inclusive of rural America, and rural and Appalachia. Um, so, as Tony knows, one of the challenges, the way that the program is is designed for those like two counties in West Virginia is I constantly had to ask people, please come and please be part of our planning group, um, for for the metropolitan area that included two counties in West Virginia. And it was really challenging. One, because they were far away from DC and people couldn't participate. And I know that in itself is a challenge for when some of those decision makers are not near where the care is being provided. But I'm just going to be candid. That's where you got to go to say, you got to go to Charleston, you got to go to Nashville, you got to go to um, Richmond, you got to go to the Frankfurt, where those services are, where those programs are based, where those states programs are based, and say, how are you being more open to what's going on in our part of the state and the
Mhm.
region? And to me, that's where, because we at the federal level provide the funds to those states and to those cities, and then they're the ones that allocate those.
Right.
Now, we also do, as I said, we do fund some programs directly. We do that through competitive funding announcements. Um, and
And
all
those
of
are
the,
grants. How do people find those grants?
so they go to federal grants, they go to grants.gov. Everything has to be, every funding from the federal government is done for grants for services is done through grants.gov. Um, and that's where you find out what funds are available. And it's every federal agency uses that platform. You can go to ryanwhite.hrsa.gov, and that tells you everything about the Ryan White program. That shows everybody that we fund. So we have a locator. You asked before, how does somebody know who's getting Ryan White funds or where they can get the Ryan White program? You can find that out from that website. It also includes the announcements that we have in terms of funding for our programs. And we we um we're we're also as I said, and I'm glad to be here to answer any questions that anybody has to say, well, how does that include us in it?
Mhm.
And to me, we have to we have to do it through a competitive process. Just want to be clear and transparent about that.
Trust me, I
Um,
know. I've been trying to shake money out of you and just have you give it to me, and you're like, no. So it's a fair and competitive process. Everybody gets to apply. Go ahead.
Right. But, these are really good points that folks have been putting into the chat about um part of it is you don't know what you don't know. And so if you're not aware that these programs are available and or that these funding is available, then um you can't be be even in part of a competition for it.
Right.
So part of it is
So
getting
two
the
things.
word out.
One, Lavina, can in our next newsletter and when we send out the notes from this, can we make sure that we put in that link to what the Ryan White programs are? And that can we also put out the link to I know that there's a Have newsletter, which I
Correct.
think is a really great thing, a great
Yep.
tool. Can we put out a link to the Have newsletter? And what I want to do is like take the last 10 minutes of this and say, if anybody has a question, put it in the chat, or you can come off of please, I need the info to pass on to all my people in recovery. Absolutely, Charlie. We will get all of that information to you, and we will send it out in that newsletter. But if anybody has a question, that they want to put in the chat, or they can, like I said, you can come off camera and ask your question. That would be really great. So you got Michael right here because he's not new to this. He's true to this. And if you have a question for him, we can ask it here. Or if you want to be able to get a question to him, you can feel free to email me or Lavina, and we'll make sure we get it to him. But, again, what we try to do, Michael, is to make sure that folks understand one critical thing. And that, and I say it all the time, and that is that so often we forget that government is made up of people. But also that I really believe that the people that work in government are critically important to the solution, and they wouldn't be there if they didn't want to do the job and they weren't committed to the people. Danny, question for you. Danny, you had your hand up. You come off mute. I see the camera. Okay.
Struggling with the mute, sorry. Thanks, Tony, and thanks for being here today, Michael. I think my big question is, so I run a syringe program in Roanoke, and we do a lot of HIV navigation. I was looking into this the other day, and we are currently serving 15 people that are living with HIV among our participants. Half of them are in care, half of them aren't. There's a lot of just I'm sure you can, when I say a chaotic drug user, you know
Yep.
exactly what that looks
I
like.
do.
And so my question is I've been in HIV work for 15 years now. I lost a family member in the 90s to HIV. And a lot of my work in Atlanta was very focused on sexual transmission. And so my question is like, what work is being done? I feel like harm reduction started as a response to HIV and was a part of ACT UP, but then became very much situated in the LGBTQ community as a sexually transmitted disease and not so much as an injection transmitted disease. And so my question is like, what's work being done in the HIV space now? Because it's almost like we have to go back to our roots, because the people that are now contracting and dying from HIV, one of my counties that I serve, is a part of those 220 counties identified by the CDC as
Mm.
vulnerable to an injection-driven outbreak. And so I feel like we really have sexual health on lockdown, but kind of what's coming down the pipe and what are kind of the higher ups at the HIV response kind of doing to reposition themselves into injection drug use? Because I think that population requires, it's a lot more expensive to reach that population and requires a lot more patient navigation. And so just curious about kind of what you're seeing both in funding priorities and in kind of resituating how they're coming at this.
That's a great question. Because I worked on this, well, way back when, but then also in the DC area in terms of our harm reduction and syringe programs. And you're right, it's kind of like drop down in terms of the visibility. Because in some ways, and I only say this out of deep commitment and care about it, is that programs were so successful in addressing injection drug use as a transmission. When I was in DC, we went from 150 cases a year, newly diagnosed, attributable to injection drug use, to like 2. And that sort of changed the visibility and changed the focus. And then the attention on the opioid epidemic sort of shifted to a lot of harm reduction programs turning into opioid treatment. Certainly opioid overdose response, but then also into treatment directly. Almost all the programs in the DC area are now provided directly.
Right.
So
I think just to interrupt, like I think from an urban perspective, I would agree with you, but like my
okay.
buddy at the syringe exchange up in Maine, in Bangor, 30,000 people, he had 26 positive HIV cases in 1 month. And like
Right.
that's what keeps me up at night is this like HIV novel community. Like this, there's not a history of HIV in this community. And so once a vector comes in through injection drug use, it just spreads like wildfire, even in a syringe exchange program. Like my buddy in Bangor was running a program and it still spread so rapidly.
And we saw that in Indiana. I saw that in Massachusetts. We've seen it in other parts of the country, as in Maine, as you noted. So the federal side of it is on the tricky side, as you know, because we do say within the Ryan White program that you can use Ryan White funds for syringe related services. You can't use the dollars to buy syringes. We're prohibited on that side. But the program side, yes, you can integrate harm reduction in your programs that are serving people with HIV. And I think that there's, I guess to your question is kind of, is it the prevention side? Because our services, technically, we don't fund, as Tony said earlier, Ryan White doesn't fund prevention programs. But we do believe in this kind of status neutral approach that says, well, if you can get somebody in to help them figure out what works for them in terms of care, that could include HIV care, we're there 100% for you. I do think that one of the strategies out there that we're very encouraged by is the long-acting injectable, because, well, one, as people are familiar with injection, and therefore using it both as a prevention strategy. Right now, you can get that shot every 2 months, and that prevents you from getting HIV, but it
Mhm.
also treats your HIV. And it's actually more effective than oral medication. There's a new one out there, lenacapavir, that we're looking forward to, that's now every 6 months. So we could be in a place where we could use these treatment options and prevention options in a new way for people that might be easier for people to address than taking daily or oral medications. Because when it comes down to it, the only way it works is if you're taking it. And we know that people in chaotic lives, chaotic drug use, as you mentioned, Danny, taking daily medication, storing it, remembering to take it, those can be very challenging. So that's where I think long acting is going to be a key option for people, and how we can make it simpler, because right now it's complicated to administer. And
Yeah,
that,
we're actually, so we're working on a pilot with our local health department trying to, the issue is that our Medicaid in Virginia requires treatment failure on oral before
yes,
them into injectable. And that's like an impossible barrier. If I can get somebody in, I'm not going to get them in for like 3 appointments to fail and then
right.
set up for the injection and then get the injection.
Okay.
So yeah.
All right,
And
Danny, let me go.
we're also talking with the FDA, because right now the indication for cabotegravir, for Cabenuva, is you have to be suppressed. Well, that kind of seems counterintuitive to the medication, because the success seems to be for people who are not virally suppressed. Getting them on the injectables actually changes changes the story. So making some of those changes, I think, as you just mentioned, are going to be key. Getting rid of those barriers around who can be eligible, and then how to cover the cost of it, because it is way expensive. And so that's why some of the insurance programs have put these limitations.
So
Thank
Michael, thanks, Danny. Michael, we've got a couple of questions regarding, and I know some of this is going to be, I have no idea and I cannot answer. But one of the questions is what is going to potentially happen with the new administration? Will there be cuts to Ryan White? Will the program stay the same? What's likely to happen?
Well,
What had happened, what we say
that's
in
a
the hood
great
is, what
question.
had happened was, go ahead.
What happened was, so we haven't gotten to the what happened was yet.
Okay.
I would say that the Ryan White program has always had a lot of bipartisan support in 34 years, even under the last turn for the incoming administration, incoming president. That's when the ending the HIV epidemic initiative started under President Trump. So I can hopefully say that the um, what I don't know the answer to that question. What I do know is that we remain mission driven with the Ryan White program, and at HRSA and HAB, we're 100% into the program and making sure that its history continues of serving people who not always had access to services and to care. And so that's what we're committed to continuing.
So if past is prologue, what we can say is that the incoming administration did support ending the HIV epidemic, which identified actually rural communities on the front end as the
Yep.
first part of
Yep.
the ending the HIV epidemic and to initiative that it did. I don't think in the second tier of cities, I don't know if those were ever necessarily funded, but that focus on those smaller rural communities remains intact. And I think that
Yes.
one of the places where we actually may have a bridge or an opportunity if we can keep those intact and build on those. And I think we could build on those with a quote unquote syndemic approach. I think one of the things we've been talking about a lot is, can we kind of add on to that opioid settlement dollars and look at a way to actually kind of do that as a magnification, or being able to look at potential threats in the future. If anybody else has a question, we're over time. But Michael, I gotta say, you're not new to this, you're true to this. And no matter what kind of happens in the future, I think that what you are an example of why we do this, right? Is that we know that we have individuals who work in government, who roll up their sleeves and do the job. And it is not an easy job that you have, because and I know people on this call may not believe this, but I was not always the passionate thought leader that I am today. I was a bit of a, you can call it whatever you want to, and I'll call it but let's just say I didn't always approach our federal, state, and government partners with the sense of ease and grace that I like to think of myself doing today. And I know you have to deal with a lot of people who come for your throat on the regular. And so what I want you to always know is that everybody on this call, everybody here sees you as a thought leader, thought partner, and we want you to see us as one too. So come back to us as a community of people in rural America and say, what can we do? What should we do? What are the advancements we can make? We want to be a partner with you in this, and each person on this call has their own level of expertise. But again, I always want to just thank you for your years of service. I want to thank you for what you continue to do, and what I think I know that you're going to be able to do in the future. So again, Michael, thank you. If you have questions for us, feel free to ask them. If you have a need of us, feel free to reach out. And again, Michael, thank you. Your last call, our last partnership call for the year. And I don't think that we could have closed out with a bigger, brighter, and I think actually more forward-thinking opportunity. Michael, thank you so very much.
Thank you, Tony. Thank you, everybody. And I look forward to coming back and hearing and talking some more.
Perfect. Syndemic Summit, September 19th, 20th, 21st. We hope you or somebody from your team will be there to join us there live and in person, so that we can talk about the work of HRSA again in the syndemic approach. So those of you that didn't know, Syndemic Summit, 19th, 20th, and 21st, and it is going to be in West Virginia, in Huntington, not at the Greenbrier this year, at Huntington. So get there, get square, you're on right. All right. See you, everybody. Thank you,
Thanks,
everybody.
everyone. Happy holidays.